The session is about use of routinely collected data in health research. And often as researchers, we are looking for routinely collected data that we want to either enrich with other data, or we want to use that data itself as the core of our research projects. And my name is Lex Burdorf. I'm a professor in public health. I have used myself lots of routinely collected data and linked them in different ways to answer particular questions that sometimes are otherwise not answerable in research. For example, one of my favorite studies as an example is linking data that I had from the cancer register with data from general practice to investigate which people who had contracted mesothelioma, a particular cancer due to asbestos, were also exposed to asbestos in their home environment. And through the linkage we could identify persons, zip codes, addresses, and we went back to these addresses and tracked people down and interviewed them. And that was kind of complicated for privacy regulation, but from a societal point of view, that study was very influential because we could demonstrate that there was a huge pollution of asbestos that caused actually every year mesothelioma cases. So that was an interesting example. In this panel, we have collected different speakers, and I say different speakers from different countries with different perspectives. And the idea is that we first will have 5 speakers for the lunch that will express their ideas, how to deal with these issues. Then we have 4 speakers after the break, and then we will have, I think, 25 minutes for debate. And the debate will be with you. And I want experiences from you, the audience, to be shared in this room, ideas, suggestions, case examples, so that at the end of the session we have learned a lot about how we can move forward the debate on the appropriate data protection regulations for use of routinely collected data. We have speakers, and we are going to do a little bit of a roundabout, because I will ask each speaker to sit after on the seat next to the laptop and then give a short presentation. And I will start off with Magnus. Can I ask you to give a presentation and then...
Thank you. My name is Magnus Stenbeck. I come from the Karolinska Institute of Sweden. I will talk to you about register-based research based on the Scandinavian perspective and data protection. Now, register data in Sweden very quickly. What is it composed of? It's central authority data. We have at least around 50 national registries in different authorities. We have they share the property that they are complete. They cover the whole population. We have national data on health, cancer, causes of death, hospital events. We have a national prescription drug register, dwelling register, which is our census, income, taxation, etc. We also now have a growing number of national healthcare quality databases. That is clinical databases on treatment and care taken from patient records and put into national registers. We also, of course, have biobank data. They are not really termed registers, but they are clinical and research generated biological samples, and we have information databases that will tell you where samples are located on which patients. Now, What can these data be used for in research? What have they been used for in research? And what are the prerequisites for their continued existence as data sources for research? I will give you a couple of examples of register-based research, and then I will relate that a little bit to the prerequisites, the legal prerequisites for the continuation of this, and then put it in perspective of the proposed new legislation. The first study I will describe to you was published 2013. It deals with the risk of heart disease in women who were radiated for breast cancer. This is a register-based case-control study of 2,200 women approximately who underwent radiotherapy for breast cancer between 1958 and 2001 in Denmark and in Stockholm, Sweden. The data for this study was taken from national cancer registers, from clinical registers, from the National Hospital Register, and also from cause of death registers. Women with pre-existing cancer or pre-existing radiation experience were excluded, and the dose of radiation was individually measured by looking at radiation protocols from the hospitals. These women were followed for up to 40 years from the beginning to the end. It shows that exposure of the heart to ionizing radiation, because especially when you radiate the left breast, it leaks over to the heart, increases the risk of subsequent ischemic heart disease with up to 116%, independently of the earlier risk profile. So for everyone, it's a risk increase of up to 116%. These effects started within 5 years of the radiation, lasted for more than 30 years. Some 1 million new cases per year of breast cancer patients worldwide. 90% of them survived for more than 5 years. Many of these women receive radiation therapy. This causes a long-term increase in the risk of heart disease. Hence, doctors should weigh this against the benefits of better tumor control when using radiotherapy and treatment. This study could not have been done without this long and complete register information containing individual records for decades. That's my first example. Second example, K-vitamin injection and childhood cancer. Newborn children are injected with K-vitamins to provide protection against infection in early life. A doubled risk for childhood cancer was found in a British case control study compared to oral intake of K-vitamin. Injection provides better infection protection, but this might be a risk. Should clinics change practices and use oral administration, K-vitamin drops instead, based on this threat? We know that case control studies like this one are sometimes unreliable, so the BMJ called for prospective studies on this topic. We used the population registers to do a large retrospective cohort study. The Swedish Medical Birth Register had 1.4 million newborns between 1973 and 1961 that we used. Data on all cancers in the population are in the cancer register since 1958. We found 2,400 cases of childhood cancer, 1.3 million without cancer on data from the birth register by combining those. Maternity clinics filled in a form about the administration method that they used, and we found then 1 million injections and about 272,000 by oral administration. We could quickly establish that K-vitamin by injection is not associated with any risk of childhood cancer. The relative risk here was virtually exactly 1. This was published in the British Medical Journal in 1993, a long time ago. The study took 3 months. No change in clinical practice was needed, and I might add, it was not expensive either. Evaluation of cancer screening. This is what they say in Norway, and we know that cervix cancer screening, for instance, has decreased mortality in cervix cancer by some 40%, I would claim. An indispensable tool in the evaluation of screening against cancer is cancer registration, covering the target population of screening. Should have been operating for a long period before starting screening in order to provide useful reference values. Some programs are aimed at reducing cancer mortality. In that case, the estimation of effect is dependent on an appropriate and complete registration of the cause of death and a cause of death register that can be combined with the cancer register. Some programs may aim at reducing inequality. In that case, the effect must be evaluated against appropriate and complete data on socioeconomic status. Register-based research provides quick answers to important health questions. It has unbiased data. It does not, like survey data, have 40% on non-responders. Fast and cost-effective results, superior power. You have very many observations, as you saw in the last study. Rare events or diseases and their combination can therefore be studied. Sample data can be combined with register data if we know that all the individuals in the sample are in the register. No data are lost to follow up. It may be the only option when randomized trials are ethically impossible. One good example of that is studying the risks of smoking, for instance. Prerequisites for this. Well, we need completeness of data. We need no missed or no deleted data. We need a common personal ID number which is used in all registers so that the appropriate data can be combined. We'll need long series of error-free registration of health and socioeconomic data. It has been suggested to use pseudonymized data instead. Does it work? They are personal data, but the identifying variables, several variables, are kept separately from the other data. Simulation of errors in linkage based on this has shown major effects on the estimates of long-term cancer survival. Without the use of a unique personal ID number, it's common to miss around 5% of the links to the date of death. Simulations show that if you do that, 10-year survival will be overestimated by over 10%. Pseudo number series differ across different databases, so they are difficult to combine based on the pseudo number. This is a picture from a Danish article showing incidence and mortality trends based on identifiable data linkages in Scandinavia. There's a consistent upgoing trend in cancer incidence and fairly consistent downgoing trend in mortality. Compare this to pseudonymized data from some of the Länder in Germany, shows an erratic picture with strange changes. In some countries, some Länder, it seems like the incidence goes down. There are jumps in the data and so forth. So these trend estimates become unreliable. Ethics. One ethical principle is to save lives, another is to reduce suffering, a third is to not cause harm, a fourth is to protect personal integrity. The effort to protect and enhance personal integrity in the new legislation proposed is very important, but we must also keep the opportunity to use register data for research in order to find answers to important health questions if we can. This is an ethical goal as well. Therefore, we must find ways to enhance data protection and allow register-based research at the same time. Some of the problematic issues related to the data protection reform is the purpose limitation principle, saying that you can only use data for the purpose for which it's collected. The general exemption for research is removed in the Parliament proposal. The right to be forgotten. Completeness of historical data must be guaranteed in order to get unbiased studies. Informed consent. Data from all groups is needed. If you need consent, you will typically often get biased samples. And it cannot in practice be obtained, of course, for very many observations. So in Sweden we use the ethical vetting board, which is able to waive this requirement under special circumstances, and those are mostly large scientific population studies where it's impossible to obtain consent from everyone, and where we use only previously collected data and don't go out again. Data security, finally. Data should be carefully protected. There are numbers of ways of doing this, and I will not go into that, but pseudonymization does not work well. Thank you.
Thank you very much. I think these were, say, classical examples of how you can use routinely collected data very efficiently to answer urgent questions with high relevance for public health. I would now like to ask Matti Rookus, who will give her presentation. She works at the Dutch National Council Register. And before giving her the word, I would like to introduce one more member of the panel. That's quite essential. Sjaak Nouwt, he is the moderator of this session. He will take care of the debate we will have after lunch. So any questions that will arise during the presentations, write them down or remember them, and make sure you communicate with Sjaak or me during the break, or remember your question when we give you the opportunity after the lunch break. Matti.
Thank you. I'm a researcher. Can you hear me like this? I'm a researcher in the field of breast cancer, and I will give you some examples of problems that would arise if stricter privacy regulations would come up, especially with a focus on the narrow informed consent. And I will also end with some possible solutions to these problems. What is observational medical research? We address questions like how often does a disease occur? Is there a trend in time? As the former speaker has already indicated. We look for causes of the disease and whether it can be screened and whether the screening is effective, whether the treatment is effective and should be focused to specific subgroups in the field of personalized medicine, and what are the late adverse health effects of the treatment. And what would narrow informed consent imply? That is explicit agreement from an individual to use his or her data for this specific research question. It's completely the other side as compared to what was the first section in this room. Of course, privacy issues are important and they should be protected. And narrow informed consent is one tool to do this, but has some very important drawbacks. Let's do an observational study on the question whether chemotherapy improves survival. Here you have 4 women, or 400 without chemotherapy in green, and in purple those who received chemotherapy. You see that half of the group who did not receive chemotherapy survives, while 3/4 survives with chemotherapy, which means that chemotherapy improves survival by 25% in the real situation. What if we did an observational study? In the first place, regretfully, we cannot use anonymized data for which the informed consent would not be necessary, because we need to factor time. We have to follow a person in time to do this research. So we need informed consent, and a narrow informed consent would imply that we get permission to use the data for this study on chemotherapy and survival. So we ask this question and include 6 of the 8 persons, 2 in the control and 4 in the exposed group, And what you can see is that all those without chemotherapy survive after the start of the study, and again 3/4 of the exposed group, giving a result of this study that chemotherapy worsens survival by 25%. And this is completely wrong conclusion, of course, based on the fact that we miss the failures of the treatment. So what would be the solution? To start before the diagnosis, so to include new cases of breast cancer, which would mean that we are no longer able to use the existing information, and we have to repeat our mistakes from the past to learn from that. So I think nobody wants to have this situation, because it will be an enormous step back, and we will become dependent on our medical practice on US studies or studies conducted elsewhere in the world. What if narrow informed consent should have been introduced in 1995? So we go back in time and do what we may be obliged to do in the near future. At that time, immunohistochemistry was brand new and booming, so of course we had asked the permission to include that into our study on chemotherapy and survival, so that we could classify the breast cancer cases according to the types of the specific tumor types. However, several years later, a completely new type of tumor characteristic was possible to establish the tumor genetic expression. If we could not do this research because we had no informed consent at that moment, so we would not have been able to show that specific genetic profiles do not need chemotherapy any longer. We would not have the mammoprint that is now included in clinical practice, and many women would still be overtreated with chemotherapy. So some of you might have asked themselves, why not again ask the study population, can we not include this genetic expression profile in the study? This is the natural characteristic of research is in fact that it is renewing, it's innovative all the time. So in fact, this study population should have been approached almost every year with another specific study question, and of course the people will be tired from all these questions. They will not refuse, they will not answer yes, they will just not reply. So this will have a dramatic impact on the study population that could be studied, which will be very selective and will also not will not qualify the data that are needed for this kind of research. A lot of money loss, study delay, and decrease of quality of data. If we ask the patients themselves, results are very mixed. Some studies show that patients want to have an opt-in, so they prefer the informed consent procedure. Other studies show that they are very all studies show that information is important. People want to be informed. But studies are inconsistent in what is the best solution. That they say yes, or that they say it's okay, but I want to have the opportunity to withdraw my data. What is consistent is that all the results of studies based on informed consent show bias. And this is really very important and a very serious aspect, because if we know beforehand that the study you are doing will not result in valid results, you can better stop doing that research at all, because it's a waste of money and effort to do that. What was the reason to do the narrow informed consent? The protection of privacy, the say on what happens with the data, and to protect the data against unintended use. If we have a research infrastructure that supplies up-to-date information to the study population on what is going on, has a sound governance structure so that the data are used for good medical research, and has an infrastructure that guarantees that the data become only available to those that may have been granted access to the data, I think most privacy issues are covered. And we may base this on the reciprocity principle in medicine. You expect to be treated according to the latest views, then the default might be that your data may be used to improve the treatment of patients like you in the future. Of course, you are free to withdraw your data. So we did in our study on familial breast and ovarian cancer in the Netherlands, which is a prospective cohort study, something like this. We tried to make an infrastructure that is really strong, but it is still based on a general informed consent. The refusers and those who retract their consent during the line are excluded from the database anytime. A steering committee decides what can be done with the data. We inform the study group on the website on everything what's going on. Ethical committee panel of patients and patient organizations are closely involved. And we also separate names and sensitive IDs from the research data. It's far beyond the scope of this talk to go in much detail on this, this flow of data, but what we did is to describe in very detail every step of data transfer or data collection. And this enabled us to see the hospital, the registry, the researcher, the data processor, each have their own possibilities to attribute or distract data. And in the systematic difference is that the IDs and the names are completely separate from the real research data. And this is enabled by the trusted third party that is closely involved in this whole system. So, if narrow informed consent would become compulsory, we will not be able to organize the registers anymore. The studies on etiology and screening might not be possible as well because they heavily depend on these registries. The difficulties on treatment studies are already showed you, and of course also the late effects will not be possible because if you have died from heart disease after radiation for Hodgkin, you will not have this person anymore in the data. So my opinion is that based on the reciprocity principle, narrow informed consent should not apply to observational medical research. And as an alternative, a strong research infrastructure resists privacy threats and supports participants' control with optimal transparency. Thank you for your attention.
Thank you, Matti. I think this is an illustration of the debate we have in the Netherlands, how patients who contribute from continuous progress in healthcare also actually have a role in that same process of improving healthcare. and how can we organize that? And that was, I think, a very good example. The next speaker is Evert-Ben from Veen. He is also the main organizer of this whole session. He is a lawyer with especially interest in issues from ethics and data protection, and he's the main advisor for many research groups in the Netherlands. Evert-Ben.
Thanks very much. Yes, so I'm a lawyer by origin, yeah, I will try to describe a little bit what my perspective as a lawyer is about the law which should become, which is not the law as it is in many countries at the moment. So it's about law, the interface between law and health care and health protection, as a matter of fact. It's not so much as about research as such. Research is a means to an end, after all. We have seen examples of that, and to my opinion, research is, at least research, observational research, whether it's with medical data or other data, is indeed always in the public interest. There can't be a distinction between high public interest, as the European Parliament wants to propose, and lesser public interest. I mean, that would mean that people who are in power say, well, we don't like these possible outcomes, like, for example, children from vegan families fare less than people who have a more mixed diet. We don't like that because we must eat less meat, so we don't want such a study. I think that's very dangerous in an open democratic society. Okay, it's healthcare as we know it in the EU, and healthcare in the EU is according to many commission statements, solidarity-based, should offer optimal quality, and should be sustainable in the longer run. And such healthcare and all healthcare protection presuppose collective arrangements. These collective arrangements are a little bit under threat at the moment. And this is a very interesting book by an English philosopher, Donna Dickinson, who describes the tension between me medicine, I'm in charge, I will do everything, and we medicine, that's medicine as we know it, which is based on collective arrangements. Otherwise, most people couldn't afford healthcare, by the way. Okay, and as then law as it might become, with the GDPR, well, most of you are lawyers and privacy experts, so I won't have to explain you what are the bases at the moment, the European Convention, the Charter, etc., etc. There are, at the moment, under the present directive, many variances in national legislation regarding health research. I mean, what Magnus Stenbeck described wouldn't be possible in France, because there it is consent or nothing, or anonymized, and anonymized doesn't work, and consent is not sufficiently given. So you don't have registries in France. In the Scandinavian countries that's possible. In the Netherlands it's possible to a certain extent. Matti didn't mention that after, in your prospective study, after asking the people 2 times whether they wanted to participate in this prospective study, the people who didn't answer at all, after 2 reminders, were still included with a lesser data set, but they were included. And that's possible under Dutch law. And also the people who have deceased. Anyhow, we have the court decisions, etc., etc. If we talk about, take a step back about law to become, then there are certain principles about legislation. It should be clear, simple, and effective. And that sort of reflects Fuller's idea of internal morality of law, which also says about law that it shouldn't require the impossible, which I translate in the modern times, that it should have a sound empirical basis. You can't make claims about the law to come, which apparently don't work out in practice. It should be more or less consistent over time. Well, we have seen that the present proposals will not be consistent over time for certain countries. And about that clear and simple, this comment by the TMF, which is a German group on sort of connected research infrastructures in Germany, biomedical research infrastructures, has made a detailed analysis, so simply not only because they don't like certain aspects of the proposals by the European Parliament, but simply, can we make sense out of it as lawyers? And they said, well, many of these clauses are so ambiguous, we cannot, it is not solid law. Simply from that internal perspective, does it not give rise to many ambiguities? Okay, and then there's the external morality. And external morality is, are we making just laws? And that is, to my opinion at least, that the law should be proportional and should have a fair balance of the interest at stakes. Now, most of this conference is about privacy as a fundamental right. Everybody speaks about that. Most of people here speak about that fundamental right. And I agree with you, it is to a very large extent a fundamental right, but we also know that fundamental rights can be constrained by law if they're necessary in a democratic society, if they're proportional, and for a legitimate aim, like for example health and health protection. Okay, then there are several clauses about freedom of the arts. This is has not very much independent meaning. There's a clause about healthcare that is in the chapter on solidarity, so that sort of suggests that it is less fundamental, but the second sentence of that clause has a very much independent meaning and is much more than simply about solidarity. There is the International Covenant on Economic Social Rights, which says in 12 and 15 very important clauses, and they are getting more. You can say that these, this covenant does not have any legal teeth, so to say. It doesn't bite, it is not self-executory, and so on. But there's a very interesting article by Donders in the Journal of Medicine. Medicine, Healthcare and Philosophy of 2011, which I really advise you to read, so that it gives more teeth, also from a global solidarity perspective, by the way. Okay, let's take a step back. What are those patient data? We have seen already that healthcare and health protection require collective agreements. Data are needed to diagnose and treat the patients. Data are at the basis of it, otherwise the doctor wouldn't know where to start, and result from it. So there, you might say, it are my data, it's my privacy. They certainly refer to that patient, that's true, and they're certainly extremely sensitive, and they shouldn't fall in the wrong hands. I agree with that. Yet at the same time, and this is where my contentious part really starts, these data are, apart from being necessary to run the healthcare system, for planning purposes, etc., that can be on a very much aggregate level. For reimbursement to whatever system is used, whether it's a Bismarck system or the National Health Service-like system, you need the data for that as well. But the most important point is that these data, which are then my data, are the same as everybody else with the same medical condition. Unless the patient would come from Mars, then, or the more likely case that the doctor has made a mistake and has put the wrong diagnosis, it are indeed your data, but they refer to similar groups of patients. And they're based on, hopefully, the scientific evidence, at least the evidence what was available at that time, of many such patients before. The data are already the result of further use. And again, they became available in a solidarity-based healthcare system. And so there is privacy in context, and I didn't invent that, by the way. This is one of the few intelligent books on privacy, by the way, I think, from Helen Nissenbaum. The context of such data, these health data, is completely different from what one poses on as his personal stuff on Facebook. It's also different from those, so to say, pupils' data, which were discussed in the previous session. As I mentioned already, they are the basis of further use, and then I think that such further use is also ethically, in a sense, essential. I mean, the contrary, at least, would be rather strange. You profit and you refuse that others may profit. Then, and Matti referred to that already, under strict conditions. There should be data safety and there should be good governance. And Matti already mentioned how the governance in the so-called Hebel study, that is the study she referred to, has been organized. With several layered sort of organization, in the end also an ethics committee which says whether the data are used according to their original purpose. And now informed consent, because that is the cornerstone of the directive, of the regulations, excuse me, but the directive as well as the directive. Okay, well, there is a sort of fetishization, it's not my word, of informed consent going on. This was an article in the Journal of Medicine and Law, I think, of 2013. Informed consent, of course, is necessary for many very important roles and to protect ourselves in society. To protect ourselves from harm, you decide what risk you take, and as informational self-determination. Well, to protect from harm, that the data will not be used against you, informed consent cannot protect you against the harm that the data will fall in the wrong hands. That must be governed, that data protection, by other means. And we simply must organize that on a higher level than the individual informed consent through these data, through strict and, and safe information procedures. Just as we cannot harm ourselves against, so to say, the threats of terrorism. And then I can assure you that the healthcare data industry, so to say, has done a much better job in assuring that data safety than assuring us against the threats of terrorism. Because there are no incidents with further use known. Okay, and then that self-determination, well, it might become already a little bit predictable, what I'm going to say now. It will be detrimental to the public good. It will lead to huge increase in costs. It will lead to bias in research outcomes. And what hasn't been mentioned yet, that usually the lesser off are the ones who will not profit then from such research. Mostly the lesser off are not so eager on reusing their data, they don't answer, etc. And so they will be left out of the statistics. And on a fundamental basis, I think that it morally undermines the solidarity as the basis of healthcare in the EU. In general, of course, self-determination stops where others are involved, and that's exactly what is happening here. Also that I didn't invent self, or I did invent it self a few years ago, but I wasn't the only one. And it's a fairly recent book from Heather Widdens, The Connect itself, clearly described this. She also makes comparisons with sort of other realms of life. For example, we have our self-determination, but it doesn't mean that we can pollute the environment, even though we might have the money to do so, and to buy a very big car and whatever. It's simply not ethical. Okay, I do think, by the way, that there should always be an opt-out. There isn't in the Swedish system, I think, there is in the Danish system, and it must, I think that is a prerequisite. Why? Because, first of all, access to healthcare should come first. People who don't trust it, oh, you say that my data are safe, but I don't believe that, well, then you won't use your data. It will also keep the governance sharp, so to say. You must always explain what you're doing, and if with that opt-out system, if you are doing something wrong, then everybody will opt out, and then you are, no, I don't want to say the word, but anyhow, then your data collection is lost. So opt-out should be there. And why can't we use anonymous data? Well, that has been told already. They are not anonymous. We have heard this morning that there are hardly any anonymous data left. And even if you use privacy-enhancing technologies, the data will be considered identifiable according to present standards. If they are pseudonymized, and I think that good pseudonymization can work, they should be two-way pseudonymized, and that's what wasn't happening in the German case. And they should be sufficiently rich to find the correlations and exclude confounders, as it's called in the epidemiological literature. And that means that they have to be also, apart from that, the pseudonym is two-way, which is then personal data by definition. Also, the data under the pseudonym will be, as research data will be indirectly identifiable. And why not anonymous data? Well, we have seen it already. There are, this is the article to which Magnus referred to. It does not work simply. In Germany, they tried to make it work with anonymous data. They didn't want to ask consent. They had very bad experiences with asking consent. Hamburg is the first example of where cancer registries died because of asking consent. It has been described by Ingelfinger in a very early article in the New England Journal of Medicine about 20 years ago. So they said that we'll do it with pseudonymized, one-way pseudonymized anonymous data, also anonymous, not indirectly identifiable. Didn't work. And other countries don't have any cancer registries left anymore, like France, which is very strict on privacy. Okay, now what? We have this new category. Will patients be re-identified? Not by researchers. They don't have any, so to say, goal in that. It's not in their interest either. Yeah? They might ask certain patients, but then via the TTP or via the general practitioner, etc., can we enroll you in a trial? But that doesn't mean that they directly identify the patients. For what purpose? And by any other, because that is the, okay, not suited general data protection, the data safety in the way that no others cannot reach this data. Well, so I come to my conclusions. I'm right on time. GDPR misses this new category of data if certain conditions are met. Only Article 10 of the regulation does. The Article 10 says that you are exempt from certain obligations of the regulation if you have only indirectly identifiable data, and to oblige with these obligations, you should do what you're not supposed to, namely to re-identify the patient. You don't want the person. So that is Article 10. But for the rest, it's not recognized. It's consent or dichotomy, or this dichotomy, I mean, between consent or anonymize. There is something in between, and this is necessary for health research. I think that in the European Parliament fashion, it also completely misses, undervalues, misses the values which underlie health research and healthcare as such, as a collective mechanism. And I'll make some very bold statement that I think that this European Parliament version is a sort of strange mix between, first of all, very liberal or libertarian, they would call it in the US, ideas about the common good, namely, I don't mind, I don't care about the common good, on the one hand, and on the second hand, it has also some sort of an influx of very old-fashioned socialist ideas about engineered society, the paternalistic view about how people should behave, namely always consent, and how science should behave, namely always a high public interest, while science as such is a public interest. Thank you.
Thank you. I guess this was a speed course in legal issues. A lot to digest, so I keep remembering you, if you have questions, write them down or remember them, because after the break we will have an extended discussion. I would like now to give the word to Christian Ohmann from Germany, who is an emeritus professor in clinical studies with ample experience in health research, data protection and privacy issues. Christian, the floor is yours.
Thank you very much, ladies and gentlemen. I want to present some experiences from an EU-funded project called Transform. And the idea behind this project is the learning healthcare system, which means a continuous interaction between healthcare and research. And the aim of the project is to develop methods, models, services, validated architectures and demonstrations to support different types of research. Epidemiological research based on existing data sources related to general practice. Then clinical trials with workflow embedded in the electronic health record and decision support for diagnosis. The project is ongoing, it comes to an end now, and the core of this project are use cases. We have 3 use cases. One is the prediction of individual type 2 diabetes complications risk using SNPs and electronic healthcare record data. Second use case is a randomized trial involving patient-reported outcomes, and it is in the field of gastroesophageal reflux disease. And the third use case is a reduction of diagnostic error by means of decision-making techniques. There are several tools developed in the project. I don't want to go into detail because this is not the topic of today, but you can see that certain elements of data protection and data security are implemented in this project already in the design. Within this project, we had to develop a confidentiality and data privacy framework. And we did this by carrying out an in-depth study of perceptions and attitudes of all stakeholders involved. And we came up with a 2-step approach. One, first of all, we developed principles providing guidance. And second, we developed a formal model to allow a structured representation of data confidentiality and data privacy issues. And we call this formal model the zones model. And I want to explain that in a little bit. What was the background for our project? Divergent implementation, heterogeneous rules and regulations, and specific needs in our project. What were the needs? The project was applicable across medical care and clinical research, so 2 totally different areas. It should take into consideration different data sources, primary and secondary data, different fields, clinical phenotype data, genotype data, different diseases, diabetes, reflux disease and cancer, and also variations between countries and regions in Europe. In addition, it should satisfy the different privacy needs for research access to primary care databases. Examples are GPRD and NIVL, GPRD in the UK and NIVL in the Netherlands. Electronic health record, family practice, electronic health records, and clinical research databases, as well as registries and genetic databases. Just to give you a short example, one of the databases involved is the NIVL database from the Netherlands. It is an extended primary care database, not only with data from general practices, but also with pharmacy data and other types of data. They are personalized in the GP practices, general practitioner practices. They are pseudonymized in the NIVL database with an opt-out approach for patients and with a trusted third party for linkage and update. And in order to perform research projects with this data source, there is a governance process has to be followed with approval, which leads to low risk by adequate measures. And in addition, the data are double pseudonymized for the researchers. Now, at the moment, is ongoing linkage between the NIVL database and between research genomic databases via another trusted third party. So I come to our model, the zone model. The zone model consists of different building bricks. And the first are the zones. The zones represent areas of low, medium, and high identifiable of patient data, and they show a kind of risk gradient. I will demonstrate that later. And zones are similar with respect to purpose, policies, and regulations. Within the zones, subzones are defined, which are comparable and can be used for the same or very similar purpose with similar rules and regulations. Then we have, as operators in this model, privacy filters, tools for anonymization, pseudonymization, and so on, as well as data linkers, which allow connection between different databases, and this can be performed one way or two-way. This is a graphical representation. This model was developed by researchers from the Transform project, including Evert-Ben, who participated. And you can see here the different zones, the care zone, the non-care zone, and the research zone. And you see that in the care zone, it's directly identifiable data. In the non-care zone, usually pseudonymous data, but not always. And in the research zone, anonymous data, but not always. And the idea is to move the data from one zone to the other zone with a decrease of risk. On the right-hand side, you see the different symbols for the privacy filters and for data linkage and for data transfer and other things. Here's we expressed all the use cases of the Transform project with this model. Here you have a picture which looks a bit complicated of the NIVL database. You can see on the left-hand side the care zone where the data are collected by the physician. And these data are transferred into the non-care zone. And here we have the so-called governance zone of NIVL. And in order to do this data transfer, privacy filters are applied. And these are split up the data into two databases, which are again linked by a trusted third party. And from the database A, with again some privacy measures, with some privacy filters, data can be transferred into the research zone where the researcher does his clinical trial. So what is the essence of the discussion and of the work with our model within the Transform project? First of all, the legal architecture of data privacy and confidentiality, which means consent, anonymization, authorization, is currently under revision with the European regulation. And we observed that there is a major problem with terminology and definitions. A lot of new terms are introduced which are partly contradictory. We now have standard instruments, anonymization techniques available, which are propagated by different organizations, quasi as standards. But even using these standard instruments, a risk of re-identification remains. Having in mind that today, often we have very rich data. The conclusion is that usually a risk assessment for deployment of data is necessary in order to estimate the risk together with a privacy impact assessment. And that's my main point I want to make, is that in the discussion it came out that we have a move from a dichotomous consideration, this is consent or anonymization, which is for me not possible anymore, to a risk-based consideration and to new categories, like there's no risk, there's low risk, there's high risk. And this kind of risk-based model has already been adopted in several countries, for example, in the UK. So if we take care of the fact that there is a risk of re-identification, it's more controllable in a closed environment with adequate governance. And there's another point. There are recent IT developments. For example, IT community is working on persistent identifiers of researchers or of documents, of databases, of IT objects, and that will come in relatively short time, and that will improve the trackability and audibility of breaches of confidentiality. So in the future, not far from now, it will be quite easy to identify when a database has been used by whom, for what, and that will really help to deal with this issue. So my last slide. So what is the future role of this zone model? We think what is reality? The risk-based approach is reflected in this model. Zones and sub-zones represent different categories of risk with a move of data between zones modeled by privacy functions. New concepts, as they are discussed, like direct versus or and indirect care or safe haven, can be easily implemented in the model as subzones. And the zone model allows a formal and standardized structuring and representation of confidential and data privacy frameworks. And this allows a better analysis and comparison of all these different frameworks which are used, and it will help to identify weak points and inconsistencies. Thank you very much.
Thank you very much, Christian. I think this is another example of illustrating that the complexity is not just a simple dichotomous variable that we like to use in the data world, yes or no, but there is lots in between, and I personally like the idea of risk assessment because that's what we do in many areas. Environmental sciences, public health, it's a common approach, so why not apply this to data protection? That's, I think, a very good idea. Okay, the last speaker of this first part of the session before lunch, we have Joanna Forsberg, who did her PhD on the topic of what is the appropriate balance between public and private interest when considering the use of human materials in biobanking studies. Joanna, the floor is yours.
Thank you. Yes, so my name is Joanna Forsberg, and I'm a medical doctor by training, but I have my PhD in bioethics. I'm currently not working within the field of ethics, but in public health. So first I would like to say that I'm very happy to be here, to take part in this interesting and important debate. And I will be talking about some ethical aspects of using health data. And I'm particularly interested in this distinction that's made between medical research and other purposes, such as quality control and public health and so on, specifically when it comes to the issue of informed consent. So this is what my talk will focus on. And as a starting point, I will take this draft report of the European Parliament. But I'm not a lawyer, so I may have misunderstood something. Okay, so what is the problem with requiring specific consent? First, it costs time and money, so it may delay research, and it may even hinder research and medical improvements. It decreases the quality of data because not everyone will respond and not everyone will want to take part. So there is a risk for bias. And it may be burdensome for the individuals that must be contacted time and time again and asked if their data can be used. Now I note that this draft report does not demand consent for using health data for management of healthcare services. For reasons of public interest in the area of public health, such as protecting against serious cross-border threats to health, or ensuring high standards of quality and safety for medicinal products or medical devices. And it also does not demand consent for other reasons of public interests in areas such as social protection, for instance, ensuring the quality and cost-effectiveness of the procedures used for settling claims for benefits and services in the health insurance system. And it even defines the areas of public health as all elements related to health, namely health status, including morbidity and disability, the determinants having an effect on that health status, healthcare needs, resources, the provision of and universal access to healthcare, as well as healthcare expenditure and financing, and the causes of mortality. So this is a very wide definition of public health. But it does demand consent for medical research, stating that processing of sensitive data for historical, statistical, and scientific research purposes is not as urgent or compelling as public health or social protection. And only research that serves an exceptionally high public interest can be conducted without consent if it cannot possibly be carried out otherwise. So my question is medical research really less important or more dangerous or risky than these other purposes? And looking at it from the perspective of society or the legal regulators, I guess if healthcare is viewed as a normal public structure like infrastructures or schools, it could be viewed as enough, just putting it in place. But the problem is that effective healthcare requires research because there are many diseases that cannot be cured or treated effectively, and new diseases evolve, medications, there is resistance against medications that we have now. So then it might be that research is more risky, it's more dangerous, and there have been previous scandals, such as beginning with the Nazi experiments, the doctors that ended up in the Nuremberg trial that resulted in this Nuremberg Code, the first point of which is the voluntary consent of the human subject is absolutely essential. And this has been reinforced in many documents afterwards, but it has also been criticized. And one person who has criticized it is Rosamund Rhodes, who has said that in the context of constituting gross violations of the negative golden rule, serious inequality, egregious injustice, and worthless study designs, pointing at the failure to obtain informed consent as the ethical downfall of Nazi research seems to miss the target entirely. And it should be remembered that informed consent does not protect against harm. Also, we have ethics review that has been put in place for all research involving human subjects. So then you could also wonder if using health data or medical research is less important or more risky from the perspective of the individual. And here I think it's very important to remember that we all actually stand behind this veil of ignorance. We don't know what kind of medical needs we will have or the people that we care about will have. And we all need medical advances. We have to remember that if we don't use health data and biological samples, we have to do research in some other way. And that might include interventions that are more risky. And then, of course, we have the ethics review that has been put in place, so it should not be more risky to use data for research than for these other purposes that are allowed. And they are used anyway, the data, for quality control and public health purposes. So my conclusion is that medical research is not less urgent or compelling from the perspective of the individual who has or will develop a serious disease that cannot be cured or treated effectively, and that could be anyone. And it's not so much about the risks as about the right to decide. And this right to decide can be viewed from two different perspectives. You could say it's my right to informational self-determination versus your interest in effective healthcare, which is a solidarity point of view. Or you could see it as my interest in informational self-determination versus my interest in effective healthcare, which would be based in self-interest. And solidarity is often used as an argument in public health. So we use it as a value that can justify strong involvement of the state. We use it to justify redistribution of resources in the healthcare system. We use it in global health. We provide assistance to poor countries and societies. And it's also viewed as a European as opposed to American value. So in Europe, we are supposed to be precautious and have solidarity versus the American autonomy and justice view. And it's also often used implicitly. And then it's like used as an argument for where actions that people are willing to take to assist each other's or assist others to whom they feel connected in some relevant way. But it should also be noted that when we use solidarity, one weak point is that it depends on whether we conceive of people as singular and principally autonomous actors who form social or political coalitions out of their free will, which is like the libertarian view, or whether we see humans as defined by and inseparable from the relations that they are embedded in. That the assessment of the fundamental importance of solidarity varies. So the alternative then is to view healthcare from the perspective of self-interest. And then there are different kinds of interests. And the first kinds, the private interests, are like my interest in walking in the woods or something that I can do by myself. But then we also have collective interests. There are interests that require that we collectively do things together. And the first kinds are congruent interests, which require that public structures are put in place. So, for instance, schools. We all have an interest in education, and education requires schools. But then there are also collective interests that require a little bit more, and they are convergent interests. So they require that we produce and maintain a public good, and this is the clean environment. And this, to me, is also healthcare. So it's not enough to just build a hospital and have some nurses and doctors work there. You also have to have medical knowledge, research, and medical advances. And then there are, for completeness, also common interests, which are more values and norms, like living in a society that is non-discriminative. So this is my conclusion. Effective healthcare requires that structures are put in place and maintained, but it is not enough to do so. It also requires research that generates medical knowledge, which is a public good, and regulations that facilitate research on health data by not demanding specific consent can be justified by arguments based on solidarity, but also on self-interest. So my interest in informational self-determination should be weighed against my interest in optimizing healthcare through implementing a system where health data are routinely used to improve healthcare, including medical research. And then for public trust, it is important, of course, that there is transparency, that people know what is done and why it is done, and that it is thought of as not just something that you can't control at all, but that is, even though you cannot say specifically exactly what you want to be done with your health data, you have an indirect control through democratic institutions. And then also that you have an opt-out alternative for those who really do not want to, either for their own sake or for someone else's sake, contribute. Thank you.
Thank you very much. We've had now 5 speakers who have given you, hopefully, food for thought. We're now going to adjourn the meeting for the real food. We will be here at 2 o'clock sharply to start. 2 o'clock we will start with a couple of speakers, and then we have ample time for debate, discussions, and sharing experience with you. See you back at 2 o'clock.